feeling unsupported, or even feeling disillusioned. This gap between expectation and reality becomes a big problem during their medical careers. So, today we bring together a panel of doctors who are at a different stage of their careers, who have been students, who have had mentors, and who would soon be mentored themselves. We invite them to have an open, honest, and maybe even a slightly uncomfortable conversation. So let us dive into Guru Shishya 2.0. And to explore this question, we have a brilliant, fantastic panel today. I invite Dr. Advait Patankar, who's a surgeon who's preparing for MCH in Mumbai. I invite Dr. Geetika Gaikwad, a fresh OBGY specialist from Mumbai, and Dr. Vibhu Anand, who's a final year medicine resident at Delhi. And joining me is the brilliant co-moderator, Dr. Soumita Sharma, who is a surgical oncologist at Patna. So I hand over the proceedings to her and then we can start a discussion. Dr. Soumita.
Very good evening to all. Since Guru and Shish, this is a strong foundation for all medical students, and it's like a blessing if you get one good teacher, and for teacher also it's like a blessing if they get good students. So 3 years of residency is the period in which we all learn all the practical lessons of life, which are in our field, which we are going to practice throughout our life. So, as a good student, we need a good mentor, but we should be a good student too, so that we give our 100% to earn this knowledge to become an MD, MS, or specialist doctor, so that the people are coming into us with a good faith. We can learn at max in this 3 years. So this is an important point. All patients are trusting us and they are coming to us. So good teacher is important and good students are, although it's a very important. So with this I am starting with a question with to Dr. Patankar. What should be the ideal mentor look like, and how can they create a positive impact on their students life?
Firstly, thank you, madam, for having me on this platform. It's a privilege to speak in front of stalwarts like Mathur sir, who himself has mentored generations of surgeons over the decades. I think when we first think of the word mentor, the first thing that comes in mind is academic mentorship. However, I think this term is a multifaceted term. Of course, probably the most important thing is academic mentorship, wherein a big part is recognizing the academic potential of the student, helping the student grow, and optimizing his or her abilities. Mentors do provide great academic and career guidance, exposing students to various fields. However, an equally important aspect is a non academic aspect. Leadership qualities, communication skills, professionalism, ethical integrity. These are things that need not necessarily be taught directly, but can just be observed and emulated by students as well. And on a more personal note, I think if a mentor builds a good relationship between himself or herself and the student, being approachable and understanding of the student's problems, then this would also optimize the student's growth and to fulfill their abilities.
So great, Advait. Very, very well answered. So one thing to remember is that mentorship, as Advait rightly said, not always is it academic, but it's also all about bridging and building personal relationships, which you would carry to your medical practice as well. So I would like to get all three of you for this next question. So I want you guys to share a personal experience where a mentor had a profound impact on your journey, and when a mentor's guidance actually changed the way that you think, or probably something that changed your medical career because of one advice. So Advait, let us start with you.
So I distinctly remember a case that I saw in my unit during my general surgery residency. A senior resident in our unit was actually operating a laparoscopic cholecystectomy, which is quite a straightforward procedure. But he inadvertently transected the common bile duct during that procedure. Now, the head of unit under whom the patient was primarily admitted absolutely hammered the SR in the OT naturally for this mistake. However, the HOU himself went and counseled the relatives and said that he was the reason that this complication had occurred. Not only that, the very next laptop that was operated in our unit was assisted by the HOU, and the SR, the same SR, was the one who operated the case. So this taught me a couple of things. Firstly, constructive criticism definitely necessary, but also backing your juniors at the time they need most, because this was such a shot in the arm for the SR, who otherwise probably would not have touched a laparoscopic instrument for a long time after.
Absolutely brilliant. And I think I had a similar episode when I was training. So, as respiratory students, we have to do a lot of bronchoscopies. I remember there was one time when I took a biopsy and the patient bled torrentially. I wanted to stay away from bronchoscopy for some time, but I had a mentor coming in and telling me that you have to start tomorrow, because if you don't do it now, you will be put off bronchoscopy for the rest of your lives. So that is very, very important. Dr. Gitika, let me get into you. Can you share any experience in your medical career?
Yeah. A very good evening, everyone. I would like to share one very similar thing that happened with me during my residency. So it was our emergency day, and it actually made me think in a very constructive manner. So this patient, she came a very poor follow-up patient, and she came to our emergency, and she had some past history of some heart disease. And when she entered in our room, and she had fetal distress, which is naturally like we just rush that patient from our emergency to directly to OT. So in case of this fetal distress, we all were in distress that moment, and even the anesthetist, everybody. So we just took that patient inside in the OT table, and she had some heart disease which was repaired, and she was very poor follow-up. So we didn't know what it was basically. So we informed this patient to our head of the unit immediately, and we took the patient on the OT table, and then she said, "No, let the fetus. We are not much worried about the fetus, but we don't know what the patient would have, what the heart disease she might have, which can be very dreadful for that patient during the surgery." So one thing that she said, you should know when not to operate. I mean, this is the thing that I feel that I will carry throughout my career, that when not to operate, when to stop. So that patient actually had an unrepaired ASD basically, which was 3 centimeter big. So we were like, it was very good that we stopped at that moment. Yeah, that is one thing, when not to operate is a thing that I learned from her.
Very, very wise words. I think these messages stay for the rest of your life in your medical practice, isn't it? Yeah.
Yeah, yeah, yeah.
So so going to Dr. Vivu. Dr. Vivu, do you have any such experiences?
Good evening, everyone. Thanks for being getting privileged to in this platform. So the I am doing my final year residency at Gangaram DNB Medicine. So I got many of the experiences, in which one of the experience I would like to share, that generally ICU patients, the relatives are very much concerned about their patients, what is the ongoing treatment and what is the further treatment plan or what active management is needed. So the relatives are very much on the top of the doctors, that what we are doing as in a private corporate hospital. So our mentor, the most important thing he did, that he told me to counsel those attendants. So when we start to counsel those attendants, at the moment, it's not the thing that you are only facing their questions, but as well as you are exploring that how you are trying to go for further treatment and further plan of the patient, and how you are going to approach the attendants who are aggressively in some way on the top of the doctors, that what you are trying to do and what the further thing it will be going on. And he always said to the attendants, and he always told me to tell them, take one day at a time. Even any positive thing, that the patient is off inotrop, off oxygen support, out of ventilator support, but never tell the patient that the patient is all good. You have to say one day at a time. Otherwise, somewhat, somewhere, when some things will happen wrong, then you will be under trap. So better to say that one day at a time, and that was the most important experience that I had learned from my mentor. Thank you.
Very, very well
Similar
put, Vaibhav.
experience I have learned about my presidency, that one of the day, so since first year juniors are full of surgery residents, full of dressings, morning to morning 3 hours for dressing period for the first year. So I was doing a dressing of pick line, and I was not knowing what is the pick line. It's so delicate to deal with, and I was doing rough and tough dressing, and coincidentally I cut that pick line. And at that time pick line was of matlab patient somewhat Kokila Ben and some private corporate hospital he did that. But to our hospital it was not that great thing, but it was of 1 lakh or 80,000 cost of that pick line at that time. And the patient was madam ne kaat diya. And my guide or teacher has defended me, and he doesn't utter a single word to me for that thing. But for daily dressings, he used to pick me, what you have done, this should be done. But for that pick line, which will cost 80,000, patient attender was getting panic. But उन्होंने मुझे he not a single pinch of word for that matter. So it was like a great respect towards him, and it will be lifelong. So, good mentors, good teachers know when they have to scold and when they have to teach them the lesson. So, it's very important point. If mentors give their impact on our life, and we also know when to what to teach and where to teach our juniors, so that we they can learn things better. So, on this note, I am moving forward to Dr. Gitika. What are the some common challenges student faces in their relationship with the mentors, and how can these be addressed? Dr.
Okay.
Gaikwad.
Uh, yeah, yes, ma'am. Am I audible?
Yeah.
Yeah. So I want to highlight on a few challenges that a mentor faces with the mentee is I think first that comes to my mind is time constraint. There could be at times that when a mentor is at some work or a mentee is like as residents, we were always running from this ward to the other ward. So I think very less time that we got to communicate with our mentors, first thing. Second thing that I want to highlight is there could be some sort of communication barrier between a mentor and a mentee, which needs to be overcome by a dual relationship, basically. And it's not only about the language barrier, but there should be some sort of empathy between the both of them as they interact with each other, not only on professional grounds, but also if a mentee or a student is facing some personal issues or some, there should be a wholesome guidance for the student from the mentor. The next thing that I feel is the difference between independent decision making by a resident versus guidance by the guide. That I mean to say is, as a resident, I felt a lot many times that I think this particular thing is correct for the patient. Like suppose this patient needs to undergo a C-section, but my guide would say, no, out of her experience, maybe that no, this should not be the mode of delivery for that patient. Like she can undergo, if she's a primary, she can undergo vaginal delivery, and you should prefer that thing. So I feel like there could be a difference in thought processes, and these things should be discussed in a very well mannered, in a structured manner, so that all these challenges could be overcome. So these are the things that I feel should be addressed, or these could be the challenges that a student or a mentor face with the mentee.
So it means a difference of opinion between the student and mentor. They can be openly
Yeah,
discussed with each other, so that
openly
they
discuss
can
about the things.
understand
Yes,
how to
and
proceed and why they are thinking
Both
differently what
perspective,
student is
yeah.
not thinking.
Yeah, both
Yeah,
So
perspectives should be looked into matter.
because we have only bookish knowledge and they have some experience knowledge,
Experience.
and in
Exactly.
so combination of both is necessary to proceed further.
yeah, I think
Absolutely, ma'am.
that is what training is all about, isn't it? It's about not asking the question what needs to be done, but why it needs to be done. I think that is what
Discussion.
actually, yeah. So that is what actually forms the crux of medical training, at least in medical specialties. Yes.
And a
So
student
I,
should have right to ask
yeah, yeah,
why.
absolutely.
Why
Yeah.
freely, not with the scam. Student should not be getting scary to ask the teacher ki why it is not so.
Yeah. So, Gitika, that is very, very well put. I hope so. All the mentors are listening that to keep this as a pointer of what how they need to improve, if I may say that. So, going to Vibhu. So, Vibhu, there's a between residents, there is always this fear of hierarchy or sort of a fear of judgment that someone would judge me for my decisions. And so, does that actually stop students from seeking help? And as mentors, how can they actually them make themselves more approachable to counter this issue?
Yeah, absolutely. So a very good question raised by you, and these things have already been with us when we are since in final year residence. So the thing is that when someone has doubt, so the thing is that everyone have done their undergraduate and have qualified a very prestigious exam and have came here. So when there is some small doubt, even that doesn't mean that high level doubt or any small doubt, there is always a hindrance inside the resident that if I ask what the consultant will think about me, if I ask what my resident friends will think about me, that he doesn't know this little much thing. This causes the main problem that we fail to ask the consultants in front of our residents. So issue happens and everything gets there is a scary things in between as well as in between the consultants, and this has to be tackled. I think this should be tackled that every resident should have a mentor and personal mentor, and they could have discussed these things not in front of a group, but they can ask and they should be easily approachable so that we can clear our doubts personally, and the mentor should also be act softly to that resident and should clear out the things. I know there is pressure on everyone, but when the good mentorship, this allows the resident and mentor relationship very much better when he tries to clarify each and every doubt and also try to back up when there is some mistake, because we are in training period, we are in residency, there will be mistakes, and as we correctly know that everything is learned from mistakes. When you do mistake, then only you can learn. When you don't do mistakes, you cannot learn. Then you are just a framed person. That means we are doing mistakes. It has to be backed up also by the mentor. This is not there. This is wrong. You should have done this. Then it could be that to a correct position. So overall things at that, this hindrance in between the residents and the mentor should be cleared out on the personal level, that one face-to-face sitting should be there at least 1 to 2 hour or 1 hour. When the hour is required, they should discuss with each other so that small problems could be discussed.
Very well put, and I think
Thank you.
that also uh, solves the issue which Dr. Geetika raised. That is that mentors often do not give enough time to their mentees. So having dedicated sessions where there is a sort of a good, healthy discussion between the mentees and the mentor definitely could help foster that relationship even more, even better. Dr. Somita?
Yes, I'm agree. Because thing is ki students number of seats, as number of seats increasing, that one to one giving guidance is decreasing day by day. 40 seats or 20 seats each year, how a reserve for a teacher to spend that much time for the student is also a little bit issue, because nowadays, since doctors to population to doctor ratio is less, and they are phenomenally increasing the seats, they are not seeing the how much teachers are available and how many students you are enrolling enrollment, and peripheral medical colleges, district places, all medical colleges they have opened, and teachers numbers are also not there, but students are coming, so how they will learn? So this is the students which are coming from the Mumbai and Delhi, but there are many students who are coming from the 2 tier and 3 tier cities, and they have shortage of mentors also. So this is a universal issue for India. But since all our good students, metropolitan cities students are sitting here, so this is not the issue here. So that still number of students increased in each and every college every year, and the number of mentors are not increasing. So it's a difficult, but we can get one good, not matlab we have professors, associate professors and assistant professors in each and every hospital. So mentor is the one who has some students, but if we have good communication with any of the one who can guide us in the small small things, even SR, even assistant professor, if one of them, if you have good relationship, you can ask your queries.
Ma'am, can I interject for a bit?
Yeah,
So I think also sometimes we label students as grossly incompetent a little too easily. And I think sometimes that could hide some red flag signs. So it's happened with me. I am party to this. A co-resident of mine would not do his work properly, would bunk, would not turn up at all. And we would all be like, यार ये तो माफ करता है, इसको interest ही नहीं है. But then later on, we found out that it was actually something that was going on in his personal life, due to which he had some mental health issues and he couldn't complete, he couldn't get himself to work as was required. So I think maybe a high index of suspicion, since especially we have sometimes lost that one-to-one touch now, as you rightly said, maybe a way that would help many residents unmask underlying mental illnesses.
Yeah,
so your all of you should be in touch with all each other. Udhar pe there should not be a barrier. If in case somebody is facing any issue, you can ask your mentor to, sir, this is the issue, please help him. So there should be inter colleagues should be there, will be, should be good interaction. There
नहीं
should
नहीं but
not be any
yeah,
jealousy and
that
there
is
should not be any competition. All are here to learn and everybody should get equal chance to learn, because for surgical branches there are a lot of backbiting and issues are happening, so that I should get more chance, not my colleague. So this should not be there, because everybody should get will get equal chance, and everybody will get, although not today or tomorrow, everybody will learn surgery.
no, but Dr. Someta, that is right. But it is also equally the mentor's duty, I would say, to make sure that all of these things don't happen. There are many things in our residencies that are extremely toxic, but it is generally normalized because ये तो होते आया है. We faced it. That is the reason
Agreed.
I would make sure that my juniors would face it. I think through forums like these, we should make it a point to put an end to all of these things. And definitely, as Advait rightly points out, mental health issues are definitely very prevalent in medical colleges. And this is something, some sort of an emergency, a need of the hour thing that we need to put it out to different mentors also, that screening for mental health disorders and making sure that not assuming that someone is incompetent, I mean labeling him some like that potentially could ruin a medical career. So I think, of course,
I was the one who faced this all things, but at the end I realized that it's a part and parcel, and if you are overcoming all that things, means you can survive, because in future in OPDs and in emergencies you won't get very friendly relatives and all. Okay, because in mentorship all will not be a good teachers and all will not be good persons also. So you have to understand ki who is the person whom I should go and talk. There should be
I
one person.
Agreed. I mean, but I would sort of disagree with it. I don't think so. Toxicity or all of this behavior sort of prepares you for anything other than a mental health issue. Okay, so let us agree to disagree and let us go to the next question.
Okay. So, Dr. Patankar, should mentorship extend beyond academics to include career and guidance and personal development? If so, how can mentors support the student in these areas?
I think definitely it should extend beyond just academics. I think experienced surgeons have the ability to predict which way the tide is turning, and they can help students get exposed to various sunrise specialties and can actually change their future careers. Also, I think a mentor need not necessarily be someone who you have directly worked with. So, listening to an interesting lecture in a conference, reading a good research paper online can also significantly change the way in which you think about your specialty. And in terms of personal growth, I think especially during residency, which is like the infancy of everyone's medical careers, the residents are most malleable. So, leading by example in terms of counseling patients, in terms of breaking bad news, conflict resolution, I think these are soft skills that you can't learn by reading any textbook. They can just be emulated by observing someone's CV. And also, a lot of mentors are in administrative capacities. There is, I think, a lot to learn from that as well.
So
Agree.
very very well put. Yeah, so while academics is one of the most important part of our residencies, people skills, communication skills, breaking bad news, all of these things are also something, and counseling for procedures for surgical branches. I think that is also something that you would want to learn from your mentor. And it is important that if you don't actually get to learn these things, find someone. There are many, even Umang has communication skills programs. So potentially that is something that we would want to look at. And I totally agree with Advait. There are authors, there are brilliant people during conferences. You might meet someone who you think that potentially could help you in your medical journey. So going to Gitika. So Gitika, do students ever feel that certain mentor practices are outdated or ineffective? And how could medical mentorship evolve to meet these modern needs?
So, yeah, sometimes during my residency, I felt that some things felt very outdated, and few things were really new to me. Things that I felt outdated was there was no structure during my mentorship. Like it was very informal and in an inconsistent manner. It happened. Like in today, I will learn something so much during my rounds, and for 3 days I will be nothing. Like I will be doing the only my regular work. So it was very informal and very inconsistent. But I think through journal clubs, they were very, very helpful. Like journal clubs, we had journal clubs and seminars, which were actually good and which involved so much of videos and so much of presentations. So it was like a balance during my residency. Second, I would think that things should be both ways. Like we were talking about feedback or something like that. I think the entire process of learning should, like medicine is a thing that we learn through the process, and there are few things that we need to unlearn from our past whatever we had learned, because it's evolving each day. So whatever there will be things that I would know much better than what my seniors would know, and there are definitely many things that they know and they can impart on to us. So there should be a balance between learning and unlearning at the same time. So these are two things that I felt like an outdated thing. Also, there should not be a feeling of authority with a mentor when they are teaching. Like they should be a two-way communication. That's what I want to emphasize on during discussions and things. Yeah.
So, in this way, I think there should be a proper protocol which is
Yeah.
updated according to the recent evidences, so that the student can learn best what is in modern era practicing. Because since evidence are coming every day and the treatment plan is
Mm.
also changing every day, so the institution protocol should be updated uh,
With the latest
on,
guidelines.
yeah,
Yeah.
so this issue can be solved. but these guidelines can be changed by HOD and HOU only. So you can suggest them, ki, sir, this is the new thing which I came in to see, but you cannot say ki, हाँ, this should be followed. I think they will say, this should be practiced. Let's start this practice in our institution also.
So I think everyone working together as a team, saying that we are going to do this rather than the mentor saying that I am going to do this. So just a curiosity, you guys are very young. So during when I was training, there was this time when residents used to carry bags, used to carry files, used to carry books for the HOD while he was on the rounds, and escort him to his car and all. Do people still do that? Advait, Gitika, Vibhu?
No comment. No. No,
I
we
think
have
the
not done
resident, I
these
think the one
things.
who's currently doing residency should answer.
Yeah,
Vibhu.
but definitely we have not
Actually,
done carried things to the car, but yeah, we have done it like
but
for discussion. We used to sit together with files.
Yeah. We would, I mean, are you
some
still
things
doing
are.
it?
Yeah, something like not telling that properly those things, but somewhat like when you are going in rounds, opening just the door, and so that they will get pass, or sometimes just going going with him. I have to go to the third floor, but they are going and talking to you. So I have they are going to fifth floor, so I have to go to the fifth floor till they are talking to me. So otherwise, I have to tell that, sir, I have to go to third floor for my work. So at that time, it's becomes difficult. So I have to go to the fifth floor, then to drop them there in their consultant room, and then come back to the third floor. Sometimes happen those things. So
Are you
that is the
allowed to
process.
open files while giving round to your teacher? Our
Uh-huh,
mentors are very strict. They were, you have to learn by heart all the reports. You should not open the file while giving the rounds.
Yeah, so exactly,
uh,
I mean, probably one might say that this is an outdated practice. So we'll go to the next question. Dr. Somita?
Yeah, Dr. Vibhu, do the students feel comfortable discussing burnout and mental health struggles with their mentor? What can be done to create a more supportive environment with them?
Absolutely. Nice question. So the thing is that uh, more appropriately, I want to say that the mentees are actually not that much comfortable in telling those burnouts and issues, because generally we get duties twice or thrice 24-hour duties in a week. So at that time, it becomes difficult, but we express to our mentors that this is happening. But somewhat that glitch comes that they tells that in our times we had to do duties. So there is something like a gap between the, like we can say that there is a generation gap, more properly to say. But that they will say that in our times we had 50 patients and I was the single resident and I was doing everything. Nowadays we are telling, sir, we are four residents but we are having hectic duties. So but sometimes that clash comes between us and the mentors. But good mentor is that they always back up. Okay, don't worry. You are having burnout. Take rest. Or somewhat, I missed the round. Or some way, I haven't did the breakfast. Though they will say, tell that go and have breakfast, then you can join the round. So some things are good, some things are bad, which has to be taken care of. The thing is that this mutual relationship between a mentee and a mentor has to be good. Otherwise, the environment where the residents are working, that will be very much difficult, and they will experience a much toxicity, and that will affect the mental health also. So as
That's
the
a
mental health is very much required to do that, because we are having exams regularly and we have to do exit exams, so that will affect our mental health and as well as our career also. So it's better to be a good mutual relationship between the mentor and mentees in order to be in a sound mental health.
What are your working hours in a week?
uh, it's as per the guideline, it is 48 hours, but we have to work about 72 to 80 hours per week.
But Delhi is the one of the strict place to control working hours. In Mumbai, there are no working hours. Residents should available 24 by 7. But this
Yeah.
is not due to the
That is
mentor
there.
and mentee. It is like our
Uh,
India has high population and low number of
Workload is
doctors.
more. Yeah,
And
workload is more.
our teachers and mentors have already gone through what we are dealing with. So in a short, I am also being a resident now. At a present I am third year surgical oncology resident. So we also try, let our teachers should not get overburdened, let we take their burden, so that they can relax and give family time to their family. That's what I think. I don't know everybody should think like this or not, but this is not the mentor issue. This is a population and doctors ratio is the problem.
No, so
What
I
you
think, I think,
say?
yeah,
Absolutely.
I think equitable work, if it is distributed properly, I think these issues
Yes.
can be sorted out. And I think so. Again, Dr. Somita, going back to the original issue, just because a few people did it 25 years ago and they went through a lot of it, does not mean that that does not actually justify what our residents actually should undergo. I mean, I am not really sure what that actually trains you for. So,
There's a 600 bedded hospital, 10 OTs per day, but only two residents each year. So what you will do?
So, no,
There
that
is
is
no
not the
other
problem of the
option.
resident, isn't it? That is not the problem of the residents. That is the problem of the hospital. Yeah. So it is up to them
But
to have more
faced by
residents
resident
there.
only, na? But faced by resident only. And in
Uh,
DNB training, I have seen that there are only one or two students in each hospital, and they have to manage everything by their own.
Yeah, so I think this is something that we should put out. That I mean, of course, if residents are less, the patient numbers are more. That should not be the problem for the residents. But this is sort of a policy making thing. Okay, going ahead. So, Gitika, we actually did talk about this. Very short. How do students navigate disagreement with mentors while maintaining professionalism?
Okay. Yeah, navigating through the disagreements is a two-way thing again. First thing, both of them, the mentor and the mentee, should reflect on that issue. Whatever the issue that they are having disagreement on, they must reflect what through each other's point of view. They must reflect on that issue. And the second most important thing is whatever they want to discuss, that discussions should be a very private discussion, not in front of patient. And these two things, and next is obviously again a feedback loop should be there, and then we can discuss it with the patient and the relatives. So two things I want to highlight: reflect on that issue, and we discuss that thing in a very private place, so that the patient next time will not hesitate from either of them. So this I have faced personally, so that's why I was very confident to say that.
Healthy
So yeah,
discussion
this
should be there.
yeah, very healthy discussion.
So,
So
but
moving forward to all of you, do mentorship dynamics differ between surgical and medical specialties? If so, how? Dr. Patankar starts with starting. Please start.
I think I can comment on the surgical aspect of it, where a mentor has to literally handhold the student through every step of the procedure. And also, there are bound to be intra-op complications. I think calm heads on shoulders at that point in time is a great learning experience for the mentee as well while operating with the mentor. And cutting, as they say, can be used as a carrot and a stick both. So I think that is unique to a surgical specialty.
But we cannot calm their nerves while we are operating. This is their own temperament.
Absolutely, and a lot to learn from that as well.
Yeah,
Gitika and
I
Vibhu,
too,
yeah.
I too agree with what Patankar sir said. I think it's mainly for us in a surgical branch, it's more of hands-on clinical skills. And I think in medicine, it's more of cognitive, what they think, and where the diagnosis process is very tedious for them. So definitely physical hard work I find, which is more with surgical branches than and also we have to roam around a lot, many places from wards to labor ward to OTs. I think what they have is just the wards, and the place that they have is the wards and ICU. So yeah.
So
Yeah,
Vibhu,
absolutely
if you take
correct.
it to the medicine side, she just said that they just have what wards and at ICUs. So
Okay.
yeah.
Uh, Actually, I have seen my surgery residents also. So they are saying that there is much more in their branches as comparative to medicine branches, because in medicine branches they tell that no, you are just having that good relationship with your mentors, but also there is a good professionalism in between you all. But in surgical branches, they always complain that we have to something to get something, we have to be there to somewhat the surgical branches people will say much more better. So in comparatively, I also accept that I have seen many things that in comparative to surgical branches, the medicine branches are little bit lenient comparative to that situation. So I agree with both of them.
So yeah, so I think mentorship in surgical specialty is more of, as Advait rightly said, hand holding and using cutting as a carrot and a stick, while medical branches is more of how would a specialist approach a case. The thought process that what needs to be inculcated when it comes to decision making. So well done, guys. I'm absolutely amazed by how
So I think
brilliant
when you will go
you
for
three are.
super specialty, na, then medical field and decision making also come into play a role. It's like hernia and appendix, you are moving towards the cancer, or you are moving towards GERD and all, managing higher cases. So this the drawback of surgical branches, especially general surgery, that we have to move ahead for the super specialty to use our brains too.
Okay, so we move ahead, and this question was originally from Vibhu, but I would really I mean, I would really want to know what Gitika and Advait also feel about this. So, as you now transition from student to mentor, you probably will transition to a mentor in the future. What would you do differently for your students, and how can future mentors ensure that they create a better and a safe learning environment?
Yeah, absolutely. So we are just on the bridge, and might be after 3 or 4 years, I might be someone I would be mentoring. So my first thing is that to make them feel comfortable at their own level. So my main thing is that the delicate balance of mentoring is that not someone creating like you, but creating themselves that at their own pace. Like, for example, I would like to give a small example. Sachin Tendulkar, as we all see cricket, he is a good, very good batsman. But if he starts to coach and tells the batsman to play at his level, that batsman might feel a little bit low, that I can't play like Sachin Tendulkar. But when Sachin Tendulkar tries to explore the creativity of that batsman, then at his own pace, then the batsman will feel confident. So the delicate balance between the mentorship should be like that. That I should not create them like me. I should create them as at their own level. So this thing I would make first of all, and the second thing I will make, that I will make them feel comfortable and will back up at their mistakes. Yes, they all are in training phase, and we have to accept that we have to learn from mistakes. Everyone has gone through their that phase. We can't say that, oh, you had did you are did so much of wrong. Yes, I have done my same thing in my residency also. So that will create a much good relationship between the mentor and the mentees, that they will feel, yes, my mentor has already been gone through this. So that confidence will be there in between us, and that mutual understanding will develop much more comfortability in between the mentee and the mentor.
Mhm.
Very,
So
very well.
Rahul Dravid is the better example.
Advait, Gitika, would you want to add?
So
I
one thing I
think,
would love to
yeah, please go.
So one thing I would like to add to what Bibu said is I also want to be very respectful towards my mentee, like whoever it be. I want to respect their thoughts, their way of doing stuff, but also be in a my communication should be very respectful towards them. So one thing that I wanted to add.
I think, sir, one more thing in as residents to call each other sir and ma'am when between a first year, second year, and a third year resident, I think that is something that is ridiculous. Both my parents are doctors, so know that at their time they would call even up to readers and lecturers by their first name, and probably that is how they developed them as friends, and that's how they could sustain the heavier workload, maybe. I think that is something that can start with us because we've just recently passed out.
I think as we are very fortunate, we had everyone calling by their own names at KM. So all our seniors used to call us by names, we used to call them by their names. So very fortunate in that way. That's why I think that is one thing that we really connect over.
That is very, very well said. And I think this sir, madam culture is probably just a relic of a colonial past, as they say. Probably even people abroad in the US and the UK are also not saying sir, and ma'ams anymore. So definitely that is something which, I would be willing to implement in my department. So I mean, I'm absolutely appalled. I'm really envious of how bright all three of you are. I mean, that is absolutely very well said. So I mean, we have a lot of mentor. If there's anything, any comments, so yeah. So Mathur sir, any comments? Indrani ma'am, we have two really well-known mentors right now watching. So if Mathur sir and Indrani ma'am can give any comments, I think that would be great.
Let Indiani go first. Shishya.
Yeah, I just heard, the different, what do you call, opinion. And one thing which really struck me was, calling, madam and sir, even to your immediate senior. That culture was never there during our formative years. And, now what happens when the resident joins? The immediate senior has to be called madam and sir. I mean, that culture, when it started, I don't know. But then slowly, I hope this culture is coming down, because that will divide, the relationship between the mentor and the mentee, definitely.
Mathur sir, if you can have comments, please.
Yeah. So very impressed with the way these young people express themselves. Now, few things I think as a mentor, and I can vouch for me, I've been very, very strict mentor. Okay. People know that. So why that strictness has to be there? Okay, I'll just give the reason for that. See, there are two things. You want the students or residents to learn the right things. That first aim of the teacher is not the wrong things. It is easy to pick up the wrong things because you say, oh, somebody, that unit person runs away and nobody says anything. Okay, he comes late, nobody says anything. Okay, that's not the right approach. Number one. Number two, what I used to tell, and I still will tell everybody, that everybody is likely to make mistake. Even I can make mistake. Even today I can make mistake. Okay. But when you make a mistake, don't try to hide it. Accept it. See, at the time, yes, your senior will scold you, but he will not lose faith in you or trust in you. And that trust is very important. And why it is important? Because all of us are working for what? For betterment of a patient. And we should always think that we could be the patient someday, or our near and dear can be patient somewhere. How you would like to be treated, that's the way you have to treat your patient. Okay. So that is something which has to be uh, for a mentor. It has to by living with the example. Because you were asked talking about the hard work. Okay. And we give the example, oh, we used to do like this, and that's why you should do it. No, that is not the way. That's not the way. And I will give you the example that I used to walk in the middle of the night in the wards on the emergency. What is going on? Once a mentor lives by example, others will follow. They will never say why I'm being asked to work harder or extra. Second thing, at when you said the sir and madam part, I think at a level where you are residents, first year, second year, third year, I think it should be more to a friendship. Yes, you have to listen to your immediate senior because that is the hierarchy which has been created in our system. Okay. But still, you are friends. When you go to the assistant professor, associate professor, or professor, there has to be certain degree of respect, which we express through calling them sir, madam, not by calling them by name. I don't subscribe to the US system. Okay. And I think the reason for it, it is same thing what you did, that you don't call your parents by their names. Okay. It is something of that sort. Uh, yeah.
Okay,
You
thank you.
said something owning that responsibility for the mistakes. That Advait and Geetika, what they gave the example, it is important. The other thing is that, yes, the way to avoid all these things is, as a mentor, if I am the senior most person in the unit and the house surgeon is the junior most person, it's my duty, and that's what I used to follow, is to show that operation myself to that junior most, make him assist, and assist him in his first or few operations. So he learns the right things. Don't leave it to the senior resident will teach you or the immediate senior will teach you. They are also in the learning process. The senior most person or those who are well trained are the one who should be guiding them so they learn the right way to do the things. The rest, everything is, I think, brilliant.
Thank you so much for that brilliant insight, sir. So as I look in the people who are attending, I actually have my mentor also here. So there is Dr. Alpa Dalal here. So ma'am, in case if you can give us any insights into whatever was said and the whole discussion.
Yes. So, first of all, let me congratulate all of you. It was a brilliant session, very well moderated by both of you, and very good inputs from the panelists. It is important for a mentor to also understand what are the views of the mentee, because sometimes we have our own patterns and we have our own ways of thinking that how we should mentor, but how it is received by the person who is being mentored, that's very very important. And one of the point that was said, that allowing the person to flower in their own way, that's very important. Having said that, I want to tell the juniors, so you also have to understand that every mentor will have their own personality, their ways of doing things, the ways of saying that But as a mentee, you want to learn and you want to absorb maximum things from them. So I think you should keep your egos aside, and sometimes you have this concept, that oh, mentorship should be like this and should be like that. I think probably as long as you are clear that the intention of the mentor is to teach you, to make you a better doctor, a better clinician, and a better person. So you have to ignore a little bit of the different ways, and that's very important. And I would say I've been blessed to have, mentees like Tarang, you yourself, and my students who have been very humble and sometimes tolerated my difficult ways also, but that makes the mentor give more and more. Yeah, I think that's very important. Ultimately, the egos have to be kept aside, and you have to develop that bond and a relationship where both give and take happens in a very natural and spontaneous way.
Thank you so much, ma'am. And that is really nice. So, lastly, I come to one of the co-founders of UMANG, Dr. Ravindra Ghawat. He's a director of critical care. Uh, so he has mentored many critical care specialists throughout the country. So, Ravi sir, if we can have a few words of wisdom, sir. Ravi sir here. Yeah, Ravi sir, I think. I think Ravi sir is not available. Yeah. So last few words. So take home messages from Gitika, from Advait, from Vibhu. Quick messages.
I think what Alpa ma'am said really resonated with me. I think it takes great. I think putting egos aside from both sides is really important. And a take home for me would be to, of course, look at the other side as well, put ourselves into their shoes, and also learn as much as we can from everybody around us.
Vibhu. I think Vibhu is also not around. Gitika.
Yes, sir. I think what ma'am said and what sir said, we should look from both perspective and be should not have an ego and should learn and unlearn things at the same time.
Hmm. Okay.
Yeah, the last I would like to say a few words that all this discussion was very much fruitful, and the take-home message is that there should be a mutual understanding between a mentor and mentee. Somewhere, somewhat, mentees when can't be expressive every time, the mentor has to be taking that something is going different in that person, and when that mentor catches this thing because every time mentees has some difficulty to express. So this is a very much pure relationship between a mentor and mentee, just like a parent and child.
Absolutely. Dr. Soumyata, I mean, you've been absolutely brilliant. Take home messages for everyone.
Firstly, I'm thankful to Dr. Mathur sir because take home message for me also. I will be assisting in future for few new surgeries to my new mentees if they are coming under me. I will be assisting on one by one. That's the great point sir has mentioned. And so, according to me, the take home messages should be mentor is a good person who has all practical and theoretical knowledge that they can implicate, translate to us easily understood manner, and knows the strength and weaknesses of each and every student under him, and make them understand both personal and professional uh, pathways of life, how they are managing both of them, not only personal, not only professional, but personal issues also. And they themselves work ethically, morally, and full correct, then student automatically will follow them, and they will treat all students equally so that they won't be having any discrimination among them. Thank you.
Thank you. Thank you. Thank you so much. That was really great. So that actually brings up to the wrap of Guru Shishya 2.0. If I have to summarize the whole session, I would say that mentorship in medicine is just isn't about just academics, but it is also about building resilience. Sometimes just having someone who listens without judgment. The best mentors actually create an environment where students feel safe to ask, learn, and even make mistakes. Secondly, the challenges that our students face are real. The hierarchies can feel intimidating. Not all mentorship experiences are positive, but as we all heard today, navigating disagreements professionally, finding support systems, and knowing when to walk away from a toxic dynamic situation is just as important as finding the right mentor. Thirdly, the future of mentorship is evolving. I mean, we have such bright people who are going to be now future mentors. Today's students are tomorrow's mentors, and the responsibility to create a better and a more supportive learning environment also lies with them. Whether in surgery or in any other specialty, in medicine, mentorship isn't just about passing down knowledge, but it is about passing down the right values. With that, a big thank you to our panelists for their insights, to Dr. Somita for moderating the session, and to all of you for being a part of this discussion. Hopefully, our Guru Shishya 2.0 leaves us with some food for thought and a collective responsibility to make mentorship in medicine stronger, kinder, and more meaningful. Thank you so much, and good night.
Thank you.